Então, para a primeira palestra, convido a doutora Therese Johnston, que abordará o tema Princípios da Eletroterapia para pacientes com deficiência neurológica e a administração clínica da Fes em populações neurológicas. Como usar eficientemente. Por favor, doutora Therese Johnston. Therese, please.
All right, so welcome. Thank you for having me speak to you this morning. And my role is to talk to you about electrical stimulation for people with neurologic diagnoses. So these are my objectives for this morning. First, I want to talk about some of the examination items that we need to consider in determining if somebody is appropriate for an application with electrical stimulation. And then I want to discuss some specific electrical stimulation applications for people with neurologic diagnoses. And that will include some strength. I know we talked about some strength yesterday more generally. I'm also going to talk about spasticity management, range of motion, function, or FES, and exercise. So here's some of the terms. I know we had some discussion about terminology yesterday. You may see the term just electrical stimulation, ES, which is a very general term. So that encompasses many of the applications that we are talking about over these several days. NMES, as we heard yesterday, is using electrical stimulation to create a muscle response. So that is what I'm going to be talking about today, using NMES. And then a very specialized area of NMES is FES, so functional electrical stimulation. And in this, we're using NMES in a way that creates a functional activity or augments a functional activity. So a very specific application of NMES. So I'm going to go through a variety of of examination items that are important to consider. Yesterday there was some discussion about muscle innervation. So is the peripheral nerve to the muscle intact? And that's an important one to consider for people with neurologic diagnoses. We can have somebody with an upper motor neuron lesion where we have an intact peripheral nerve to the muscle. And for that person, electrical stimulation may be appropriate. However, someone who has a lower motor neuron injury that affects the peripheral nerve, then that's not going to be an application that we can choose for that person. So when you look at the neurologic diagnosis, the diagnosis itself is going to guide you as to whether you're dealing with an upper motor neuron lesion or a lower motor neuron lesion to help you determine if it's appropriate. Another important examination item is to assess strength. So in looking at strength, I need to determine which muscles are strong that the person can use volitionally in the activity and which muscles are weak or have no activation at all, volitional activation, so that I can decide to stimulate those muscles during the activity. I also want to evaluate sensation so that I know if I have to monitor the person more closely. So if sensation's intact, I know that the person will feel it if it gets uncomfortable and if it's getting to the point where skin may become red, irritated. However, if they don't have sensation, I need to be more careful in what I am doing, all right? Even though one benefit of not having sensation is that you can turn the stimulation up higher and get a better response. So you need to look at both sides of it, the pros and cons of having sensation in terms of using electrical stimulation. I also like to do an assessment of pain. So if they're having any pain in the targeted area, for example, if I'm stimulating the wrist extensors for a functional activity such as grasp, I need to know if the person has pain at the end range of wrist extension so that I'm very careful with that when I'm using the application. Spasticity is always an important consideration for someone with a neurologic diagnosis. And there are ways that we can alter the stimulation to help to minimize a spastic response. So when you stimulate the antagonist muscle of a muscle that's spastic, all right, so your agonist is spastic, your antagonist is not spastic, and if you stimulate the antagonist, sometimes you can create a spastic response of the agonist. All right, so I watch that carefully. So if I'm stimulating for wrist extension and they have spasticity in the wrist flexors, I need to look at that response carefully to see if that's allowing the wrist to extend or if the spasticity is interfering. So I'll do an assessment of spasticity. I also want to look at function so that I can determine what are the functional activities that the person is lacking, as well as think about what I may be able to augment or create for that person using electrical stimulation. Cognition is an important factor, as many neurologic diagnoses do impact cognition. So I need to know if the person follow instructions. Can the person reliably report back to me about how it feels? So I need to have that understanding going in so I understand how to approach the treatment. And just because someone doesn't have good cognition does not mean you can't use electrical stimulation with that person. You just need to be aware of that during the treatment session. I also look at caregiver assistance because for some of these FES applications, I would be sending this home with the patient, and I need to know that they have a caregiver who can reliably assist them if they need assistance. And I also like to know what other interventions are being performed, because as we talked about yesterday, these applications aren't performed in isolation. So it's possible they're working on some other activities without FES. How is this going to complement those, or if something's going to interfere? So I need to know what other activities, what other interventions are being performed. Okay, I'm going to focus on several specific diagnoses through this talk. So I'm going to hit on some important items to think about with some of the more common neurologic diagnoses. So when we're looking at somebody following a stroke using electrical stimulation, obviously we need to do an assessment of cognition to understand if the stroke has impacted them cognitively. And as people who've experienced a stroke are typically older, I want to look at other comorbidities, what other medical conditions exist before the stroke happened. And I also need to be aware of blood pressure. So it's very likely the person who had the stroke had high blood pressure, so I need to be monitoring that during the activity also. And then spasticity is always a consideration in stroke. The next condition is cerebral palsy. Children with cerebral palsy tend to have a lot of orthopedic issues, so I need to be aware of that. And what you see sometimes is that when you stimulate the muscle, because they have some changes or didn't develop in their long bones properly, that you go to stimulate for dorsiflexion, but the line of pull of their muscle is different because that bone never developed the correct torsional qualities that we would develop because we're weight-bearing. So you may see a very different line of pull of the muscle just because the bone itself is different. Children with cerebral palsy often have seizure disorders, so I'll be monitoring for those. And typically, if somebody has an active seizure disorder, I'll get clearance from a neurologist. And also with cerebral palsy, I need to consider cognition. For spinal cord injury, I need to be aware of the status of the bones. So if osteoporosis is very likely present, and I need to understand to what extent. Do they have a history of fractures? That goes into my decision making. Autonomic dysreflexia, does everybody know what that is? I'm seeing a mix, okay. So it's a condition where for somebody who has an injury at the thoracic level 6 and higher, that their autonomic system is impacted by the spinal cord injury. So when they experience a noxious stimulus, the blood pressure can go really high. So I need to be aware of that when using electrical stimulation to know if that could be an issue. So I need to monitor them closely. With a spinal cord injury, you may also have some orthopedic issues. Spasticity is common, as well as skin integrity. So I need to be monitoring the skin much more closely. All right, with multiple sclerosis, I also need to think about spasticity. But one of my biggest concerns is going to be fatigue. So am I going to fatigue the person through this activity that I'm using with electrical stimulation? So I need to know what their tolerance is for activity. And then cognition can also be impacted by MS. And in pediatric onset conditions in general, so this can be any of these diagnoses that occur in a pediatric population, I need to be aware of potential for scoliosis, hip subluxation, where the hip is partially out of the socket, the abnormal rotation of bone, which I mentioned earlier, as well as osteoporosis. Okay, now I'm going to just talk a little bit about strengthening with NMES. Some of these are repeats information from yesterday. First of all, with a neurologic diagnosis, we know decreased strength is a common problem. So strengthening applications with NMES may be very appropriate. And yesterday we heard about the differences between volitional and stimulated muscle contractions. And I think with that, if you're choosing to do strengthening, do you want the person to actively contract the muscle while the stimulation's on? Or do you want them to let the stimulation do the activity? And in the literature, there's nothing, I've seen very little on just on the combined effect. We're using volitional as well as stimulated strength in patients with neurologic diagnoses. So I tend to allow the person to assist if they're capable of doing so. I may choose not to do that if somebody has a lot of spasticity, and by them trying to assist, it just triggers a spastic response in the body. So I'll make an individual decision, but I prefer that somebody works along so that they're getting the activation through the central nervous system. All right, we also heard yesterday that strength protocols require muscle overload. And I think that's been one problem in the literature for people with neurologic diagnoses, is that protocols don't overload the muscle sufficiently with stimulation to actually show that there's an effect. So you'll see reports that strengthening with stimulation did not improve strength, but it's very likely that's because it wasn't overloading the muscle enough to create an effect. Another thing to think about with strengthening, in these patients, they may have extremely weak muscles. So if you're choosing to do NMES for one activity, you may get benefits in other areas. So for example, if you're using FES for someone who has very weak dorsiflexion, and you're using it to help them walk, they may also gain strength in that muscle. They may also have decreased spasticity in the plantar flexor. So you see some of those combined effects by doing one treatment, all right, because the muscle is so weak. So that may be enough to overload it just by having them walk during gait. And as far as the research that is available, it's really hard to determine optimal treatment strategies because there's such variability in the literature. So I'm going to talk about some studies that are out there, but just, you know, there's no great resource that you can go to and say, this is the way I need to do it. So we still need a lot of research in this area. Okay, a couple of studies I'm going to mention as far as following stroke, and this is for strengthening. A review article in 2007 showed modest support for gains across the studies that were included. And they listed a variety of different muscles where they saw gains. So for wrist and finger extensors, grip strength, hand function. And they also looked at the cortical activity using fMRI and showed that that was improved. In cerebral palsy, also very limited work. However, gains have been shown in strength, function, co-activation of different muscles, and then sometimes passive range of motion is improved. As far as spinal cord injury, strength gains have primarily been reported for FES applications rather than NMES applications. So this is another example of where FES is used and they make gains in strength as a result of that. There's also an application where you can stimulate the gluteal muscles in sitting for someone with a spinal cord injury, and it can decrease their pressure in sitting as well as increase their muscle size. And there's some ongoing work in this area. And then with multiple sclerosis, again, limited studies, very mixed results in those studies that have been published. Okay, now I'm going to talk about a little bit about NMES for increasing passive range of motion. I know this came up as a question yesterday in the question and answer period. And using NMES, we can provide repetitive activation through the range of motion. So I like to think of this as a good home program if somebody has the assistance to do this at home. Because when they're with me in therapy, I may spend 5 minutes stretching the muscle, but if they can do this multiple times throughout the day, have the electrical stimulation on, take them through the full range of motion and hold them there for up to 30 seconds, that they're getting that repetitive stretch throughout the day. And if you can incorporate that into a functional activity, that's even better. Okay, so we may have more of an effect if we can get them out of that position many times throughout the day. However, in terms of the research, there are very few studies that are published in this area. You're going to see this as a common theme throughout these neurologic applications. But the studies that have been published show that contractures can possibly be prevented, so maybe something you could start early on. That passive range of motion can increase, but we don't know the best methods for achieving this at this time. So in applying this in the clinic, your goal is to increase your treatment time. So you want your on time to be on longer. So when you're setting a machine, your goal is to have a long on time and a shorter off time. You may need to have them build up the endurance to get to that point. So in setting your machine, you want to think about keeping the stimulation parameters as low as you can, but still obtain the effect. So especially when you think about frequency, that frequency is a very fatiguing variable, that I'm going to keep frequency as low as I can and still get a tetanic response of the muscle. And typically I'm looking to get a contraction strength of a 3+ out of 5, because I don't want to force that joint through that whole range of motion. So I don't want to achieve a grade 5 muscle strength. because that's going to be incredibly uncomfortable as well as fatiguing. So I just want enough to take them through that range of motion. And then you have to monitor the patient for any soreness because you are taking them to end range multiple times. And also watching for muscle fatigue. So possibly when you start the treatment, 15 seconds on is all the patient can tolerate before the muscle fatigues. And then over time, you'd like to be able to work up to the muscle being able to tolerate a greater amount of time. And again, no consensus in the literature as to the best protocol. Okay, now I'm going to talk a little bit about NMES for decreasing spasticity. And I think this area is a little more controversial, but people do use it to decrease spasticity. There are a few different mechanisms that are proposed for how this works. One is reciprocal inhibition. So when you stimulate the antagonist muscle, it causes the agonist muscle to relax. Okay, so you can compare it to when we volitionally activate a muscle. When we activate our triceps, we then deactivate our biceps to do an activity. So the same type of theory of how that works. Another theory is that recurrent inhibition or fatigue. So this one, you're stimulating the spastic muscle itself. All right, so through the central nervous system, you're getting an inhibition of the spasticity. I think a lot of people think this is more of a fatigue issue. You tire the muscle out so that it cannot respond as strongly when it does have a spasm. And then another application, just sensory inhibition, that just the sensory signal alone can cause relaxation of the muscle. All right, so again, these are just all proposed theories. I don't think there's been a lot of proof in any of them, but these are some of the thoughts about how this is working. And again, as far as the research, there are a lot of inconsistencies and no clear protocol. All right, as far as the clinical application, so ramp-up time becomes really important in this application when you're stimulating the antagonist muscle, because you don't want to create a quick stretch of that spastic muscle. So you can make ramp time as long as you need to allow that muscle to slowly be stretched out. So if you're thinking about spastic biceps, for the triceps, I will slowly ramp them up to not create that stretch reflex. And for the two where you're going to create a muscle contraction, the theories of reciprocal and recurrent inhibition, again, you're just trying to get like a 3+ out of 5, just to take them through that motion. And then as far as the sensory, it's just to create a sensory signal. So you're going to turn up the stimulation. When you see a motor response start, then you're going to turn it back down a little bit. And if the person has sensation, they can tell you what it feels like. Okay, now I'm going to start talking about some of the FES applications. Any of you seen this unit? This is the IBRAMED's portable unit. So when I'm thinking of FES applications, I'm typically thinking of using a small portable unit. Okay, first I want to talk about FES as a dorsiflexion assist during gait. And this is one of the more common applications that you will see. So typically you're placing the electrodes on the anterior tibialis muscle as well as somewhere along the peroneal nerve. And this picture, oops, I don't think this is working. This picture shows a couple of different possibilities for electrode placement. This application is variable among different people. You may spend quite a while sometimes trying to find the best placement for each person, because the goal is that you get dorsiflexion without excessive inversion and without excessive eversion. All right, so if you think about it, if you're just stimulating the anterior tibialis, you're going to create inversion. So if the person's landing in initial contact with a dorsiflexed and inverted foot, and then they go into stance over that foot already in an inverted position, they're at risk for an ankle sprain. So I always tell people I'd rather err on the side of having a little eversion than having a little inversion to protect the ankle. And typically for this application, you're using some type of a portable unit that has a trigger or a foot switch that you put inside the shoe. I know with the portable devices we have here, there is not a trigger associated with that. So hopefully IBRAMED will consider adding one so that this could be an application that could be used for someone to assist someone walking. So with the foot switch, the ones that I use, how they work is that I put it underneath the heel in the shoe. So when the person initiates swing, pressure comes off that switch, and it turns the dorsiflexors on. So instead of using an on-off time, it's being triggered by the person initiating swing. And another option is to use a trigger that the therapist would control. So a push button so that the therapist could decide when the person's walking, when to initiate dorsiflexion for swing. That one's a little bit harder because you have to watch what the patient is doing to activate the muscle at the correct time. However, one advantage I like with that one is that I may choose sometimes not to stimulate to see if the person can do it on their own after we've done a few with stimulation. And this is often considered an orthotic substitute. So instead of an ankle-foot orthosis, somebody may choose to use electrical stimulation. Okay, so as far as dorsiflexion assist, this can be used in many different diagnoses. If somebody has an issue with decreased foot clearance during swing, and they have an upper motor neuron injury, this may be a good option. And most of the research that is available has been done following stroke. And some of these have been done with implanted systems, where there's an electrode surgically implanted into the muscle. And I'll show you some pictures of a couple of different types of electrodes that can be implanted. And where you're looking at using this for someone, other considerations are that you need to know how much passive range of motion that they have in the ankle. Because if they have a plantar flexion contracture, no amount of stimulation is going to give them sufficient clearance for gait. So I always assess passive range of motion. You need to look if there are any other orthopedic issues that may prevent them from walking, if they have any other issues around the knee or hip that may interfere. And then I also assess spasticity of the plantar flexors. If you think about when we're walking, how quickly our dorsiflexors are on and off. If someone has a lot of spasticity and I'm trying to create quick dorsiflexion, it may trigger plantar flexion spasticity. So I need to monitor for that. Okay, these are some of the parameters based on a review of our literature of what's commonly used for this application. So pulse duration typically ranges from 200 to 400 microseconds across the literature. In terms of the frequency, we're just going to increase it enough to get a tetanic response of the muscle. Again, because with FES, we're concerned about fatigue. If you want someone to use their dorsiflexors with stimulation throughout the day, the muscle has to have the ability to do that without fatigue. And as far as the amplitude, here for FES for the dorsiflexors during gait, I'm looking to create a 3- to a 3+ strength. If you think about how, when you're walking, how much you dorsiflex your ankle when you walk, all right? We don't need to use all of our passive range of motion in our dorsiflexors to clear our feet. So a 3 may be enough. So you can determine that with your patient, how much you need to increase the amplitude to get the response you want. And then as far as on-off times, here the on-off time doesn't matter because we're triggering it either by manually triggering it with our thumb switch or using a switch in the heel. All right, so the units I use when you plug the external trigger into the device, it overrides whatever on-off time is set in the machine. All right, so you can just leave that at whatever was set. It'll just override it for you. Okay. All right, and here, ramp up and ramp down. Now, I just talked about how you need to be concerned about spasticity with that quick stretch. However, even for our patients that walk very slowly, if we gave them a 1-second ramp-up time for their dorsiflexors, we just missed swing. So, you know, when you get up and walk around, think about how quickly your dorsiflexors are on and off. So a ramp time doesn't make sense. So we need to be able to create a quick response of the muscle to have it be effective. And if you have somebody who has a lot of plantar flexor spasticity, you may need to work on accommodating them to the response. It may be the first few times you use it, you get a spastic response, but the body adjusts to this, and then you can use it as an application for that person. Some other potential benefits of doing this is that somebody may gain strength in the dorsiflexors if they already have a connection to that muscle. So if somebody has a trace muscle contraction, you may be able to increase that for them, increase that strength. But if somebody has 0, pretty unlikely that you're going to create a response. And I've seen it occasionally, but I think it's that I think it's our assessment that we can't detect between a 0 and a 1 in some muscles, or the person is too inconsistent in activating it. And somebody may have decreased spasticity in the plantar flexor muscles over time by using this. Okay, as far as the possible stimulators, I mentioned I prefer to use a small portable system for this that has some type of a trigger that I can use. In the United States and other countries, there are some devices on the market that you can buy that are designed for FES during walking for the dorsiflexors. I went on to one of the websites to see if they were in Brazil, Bioness, and I did not see that they have a branch in Brazil. I was looking for some videos in Portuguese that I could show you rather than in English, but apparently they do not at this time. work in Brazil. But in the US, we have a few options for the walk aid, the Bioness devices. And there's a device in the UK called the Oddstock, which does similar types of things. And then implanted electrodes are also options. These are in research centers at this time. And the advantage of an implanted electrode is you don't have to put the electrodes on each time. So you get a more consistent response. And it makes it more spontaneous for the user, that they don't have to worry about putting things on when they're ready to walk. Okay, so one of these devices is called the walk aid. It's just a battery-operated stimulator. And these different systems use a different type of a trigger. So this one uses a sensor on the leg, and it will know the position of the leg, and it'll turn the muscles on at the appropriate time based on how that sensor's position changes. And I had one video of this, but I don't think this one's going to work, but I have a couple of others. Sound okay?
Foot drop, a devastating result of stroke and central nervous system injuries. Foot drop causes instability, diminished walking speed, and increases the risk of falling.
I don't know if they can translate this fast enough.
Now, the treatment of foot drop is stepping into a new era with the innovative NES L300 neuroprosthesis. The NES L300 restores natural ankle movements and increases overall stability during ambulation. The system consists of three main components: an electronic orthosis, a control unit, and a gait sensor, all of which communicate wirelessly, eliminating the need for troublesome externally worn wires and connectors, making the system simple and easy to use. While walking, the IntelliSense gait sensor detects gait events and transmits wireless signals to synchronize the electrical pulses delivered by the electronic orthosis. These pulses activate the nerve that causes the foot to lift off the...
Okay, I thought maybe he was translating this, so I will talk you through this a little bit. So it just shows during gait when the muscle's being activated. So you can see here a patient using this, and that it works also on grass to give him the foot clearance that he needs. Okay, you can see the difference here between with and without stimulation. And this is specific to this device, that someone can put it on with one hand. And that's his control unit. He just takes that with him, and he can have the device with him all day. In this one, they're showing it during early rehab, that you can incorporate into gait training early on. And then here's another with and without. You can see the difference of the foot. He's getting nice foot clearance. So these are a couple options for implanted electrodes. So the one that's the has the 1 centimeter marking there on your left. This one is an implantable electrode. It's a very tiny electrode that can be injected in with a needle. And the company that is working on these, Alfred Mann Foundation, which is in California, hopes to one point have these clinically available so that you can just inject this electrode into the muscle, and then you would just wear something in your pocket that would communicate with that internal electrode. I was hoping we'd have more of these available clinically at this point, but they've been promising us for years we're going to see this, so hopefully soon. And the other electrode you see there is one that I've used in research. And you'll see this in some research studies. It's called a percutaneous electrode. And this electrode is implanted into the muscle. We do this in the operating room. And then the muscle is the electrode is passed through the skin. And if there's more than one electrode, we'll have them all come out in the same area. So they'll just get passed underneath the skin to all exit at a common spot. So this currently is just a research application, but it allows us to get consistent muscle responses and to really evaluate what we're trying to create. And I've worked with these with children, and children have had them in for up to 3 years. So it's not a real short-term application, but relatively. So it's not something they're going to keep forever. And then we'll just pull the electrodes out, again, in the operating room if they have sensation once they're finished with it. Okay, as far as some of the evidence for FES for foot drop during gait, there was a meta-analysis done in 2006 that showed that on average, walking with FES led to a 0.18 meters per second increase in walking speed. Another study in 2006 by Scheffler showed that the use of FES was comparable to using an ankle-foot orthosis. And in 2011, Hackinson showed increased walking speed, and this is with the FES off, after they had gone through a training period with FES while walking on the treadmill. And for multiple sclerosis, a study by Taylor showed increased walking speed, as well as a decrease in the physiological cost of walking. And a more recent study, and this is, I don't know if you're familiar with the Canadian Occupational Performance Measure. It's a scale that allows the patient to set his or her own goals and then rate those goals pre and post intervention. So using that tool, this study showed that people reported their function was improved, they could walk farther, and they tripped less. Okay, in cerebral palsy, a study I was involved in with Orlin in 2005. This is with percutaneous electrodes, that we improved the dorsiflexion during swing and at initial contact when the FES on. So in this study, we just wanted to see what we could achieve in the kids with cerebral palsy. And a more recent study by Prosser showed similar things. This is with, I think it's the WalkAid system. It's one of the commercially available systems in the US with surface electrodes. Also showed improved dorsiflexion during swing and in initial contact. But after a training period with it, they reported the kids did not walk any faster with the FES than they did without. Okay, so I know this discussion comes up about, do you choose an ankle-foot orthosis or do you choose FES to improve foot clearance? And there are pros and cons of each. So with FES, the advantages I see are that you're using the person's own muscles. So you can potentially create a strengthening effect. And their muscles are being activated throughout the day, where if they're locked in an ankle-foot orthosis, they get little opportunity to use their muscles. I mean, that's one big advantage I see. I would rather have somebody be using their muscles than blocking them and not letting them use them. Some of the cons are FES is it usually takes longer to get the FES system on than it does to put on an ankle-foot orthosis. Usually. Depends on the ankle-foot orthosis itself and how hard it is to don. All right. Sensation is another consideration. If someone can't tolerate the sensation of the FES, then an ankle-foot orthosis may be the best option for that person. And I was thinking of another one, but it slipped my mind. All right. So it's something to consider with your patient. All right. Another potential consideration is with an ankle-foot orthosis, we can have medial lateral control of the ankle, where with FES, we take away that ability. Okay, so these are some of the key points to think about for using FES to increase foot clearance. All right, so you can assess the patient's response with any device, but you want to use some type of device that can be portable. And just so you know, in the US, Medicare has approved coverage for devices for some populations, which shows that some insurance companies in the US think that there's enough evidence to use these devices. But most of our insurance companies don't. So that's still a fight for us to show that the evidence is sufficient to get them to pay for this. Okay, now I'm going to talk about the shoulder for shoulder subluxation. So this is for patients who have severe weakness or flaccid muscles around the shoulder that are causing the shoulder joint to sublux. So they have a glenohumeral joint subluxation because of the weakness in combination with gravity. And in this, most of the research has been with stroke, since this affects more patients following stroke than other patients. And there has been research with implanted systems with these devices also. And this is a pretty common electrode placement for using FES for shoulder subluxation. Typically, we're placing one electrode over the supraspinatus muscle and one over the posterior deltoid. And then when you're using this, you also have to think about gravity, so that you're positioning the patient in a position that will minimize the effects of gravity. So if you're supporting the arm on a table to get them started, or temporarily using a sling. Okay, I see if I can get my... These lines aren't showing up too well here, but this is an x-ray of someone with a shoulder subluxation. So from here to here, you can see that the glenohumeral joint has subluxed. So now in this x-ray, we've applied electrical stimulation to the posterior deltoid and the supraspinatus muscles, and there's a reduction. So the line from here to here in that shoulder subluxation. So this is the effect that it can have. All right, as far as our parameters, again, these are based on the literature. So again, we're looking in the 200 to 400 microsecond range for the pulse duration, because we want to get a muscle response. Again, frequency, just enough to get tetany, so that we're not fatiguing the muscle. And with the amplitude for this one, You're just going to turn it up until you get the response you want, which is that you see a reduction in that subluxation. So you can palpate the shoulder, feel how big that subluxation is, turn up the stimulation till you feel that reduce a little bit. And for this, for your on-off ratio, you may start out with a lower on time while the person's building up the endurance for the activity. But your eventual goal is that you have it on for a longer period of time. So more in like a 12-to-1 ratio. Maybe you'll have it on 120 seconds, off for 10. So if you think about with a subluxation, you want to have that reduced as long as possible throughout the day to help to support the joint. And your treatment time is to have this for 6 to 8 hours. So during the day that they would have this unit on to help support the shoulder and possibly strengthen some of the muscles around the shoulder. And some of the implanted systems have had this running for 23 hours a day. All right, as far as the evidence, there's a Cochrane review in 2001 that showed a small reduction in the shoulder subluxation, 1.13 millimeters. But they also found that people had decreased pain with shoulder external rotation. So if you think about a patient who's had a stroke and the shoulder pain they may experience, that alone can be a very good outcome that you've helped to reduce their pain. In 2002, there was a study looking at FES either by itself or with more conventional physical therapy treatment. And they found that when FES was combined with conventional treatment, there was the greatest decrease in shoulder subluxation. So this speaks to what we talked about yesterday as the complementary nature of using electrical stimulation in your physical therapy treatment. And their study found the evidence with people with acute stroke, not chronic. And in 2010, an RCT showed greater decreases in subluxation with FES compared to conventional therapy. So here they did just compare the FES and the conventional. There's also a study that found some good evidence as far as pain reduction. Che has done some work using the percutaneous electrodes following stroke. And people use this 6 hours a day for 6 weeks. And in addition to the supraspinatus and the posterior deltoid, they added in the middle deltoid and the upper trapezius. And they found that there was a much greater reduction in shoulder pain for people who used FES compared to those who just wore a sling to support the shoulder. All right, so again, a really good outcome if you can significantly decrease pain of shoulder subluxation. And what's even better is people were able to maintain the change 12 months after. Okay, some key points to think about when using FES for shoulder subluxation. So that with the literature that's available now, the effects are greater with an acute stroke than with chronic. Typically, you're stimulating the posterior deltoid and the supraspinatus. And pain and subluxation may decrease. And the decreases in pain may be long-lasting. There's also some evidence to show that you may have faster improvements after stroke using FES at the shoulder. And you also have to think about your stimulation parameters, especially the frequency, keeping it low. If you want to stimulate the muscle for 8 hours a day, you want to make sure it's not fatigued. Okay, now I'm going to talk about FES for grasp. The company that makes the foot drop system that I showed you also makes a system for the upper extremity. And with this device, you can use it for exercise as well as FES. And it stimulates various muscles to allow for wrist and finger flexion, as well as wrist and finger extension, so that somebody can grasp and release. But if you don't have this device, you can also create this with a portable system. All right. Preferably one that has a trigger that you can control. However, if you don't have one, this one's a little easier to do with a bigger unit, that you just have to have the person time they're reaching with when the stimulation comes on. So when they feel the stimulation start, you can have them reach for an item such as a water bottle. All right, let's see if I can get this one to work. Okay, so he's using this during activities in therapy. And he's talking about here how important this has been for him, that he does not have the ability to grasp and release. And this has allowed him to do some functional activities in therapy and work on strengthening those muscles. It'll go back to him in a minute so you can see. So the electrodes are actually underneath those plastic pieces. So they're built into the device. So using this, you can do some early training of grasping and work on him then doing some more proximal control activities also, so that you're involving the whole upper extremity in the task. Yeah, I see him there grasping and then releasing. You know, and the goal for this man would be hopefully that he will get strong enough and enough control in his muscles that he won't need this device. So it can be used as a training device, or if somebody would end up needing it long term, it's a potential longer term option. Okay, as far as the evidence, Thrasher in 2008 showed that there are the greatest effects with acute stroke, so similar to the other systems. There's another study by Santos that showed a 10% improvement in grasping performance for people who practice with FES versus just using NMES to strengthen, where the NMES was just on and exercising the muscle. Other studies just showed improvement in volitional activation of the finger extensors, as well as increased active range of motion in other muscles, as well as functional scores. When we look at some of the other populations in cerebral palsy, there's been very little in this population. And I think this is a population that could benefit from using FES for grasp and release. There was only one case report that showed some effects. And then in spinal cord injury, there's a device that was on the market in the US called the Freehand that we hopefully will be seeing again soon. That's an implanted device. And with this, with this implanted device, there are electrodes that are implanted to certain muscles in the upper extremity, depending on the patient's needs. And this little coil here, this is on the outside of the skin. And underneath this, in the skin, is a control device. So there's a control device as well as electrodes inside. And then externally, I lost my mouse. Externally, the person attaches this component, which communicates to this box. And the person controls it by this joystick almost that's on the outside of the other shoulder. So when the person raises their shoulder, it causes their opposite hand to do something. And I'll show you a video of this in a moment. And this is used for people with C5 or C6 spinal cord injuries. And they provide two different types of grasp. And usually it's done in conjunction with some other surgeries to optimize the use of the upper extremity. So this is a young man with a C5 spinal cord injury, so he has no ability to actively use that left hand. He's using this all with implanted electrodes. And if you look really closely at his right shoulder, he will occasionally move that to lock and unlock his hand and to grasp and reach. So again, someone with no active control. He has no active wrist extension, anything in the hand. And one of his big goals was to be able to eat pizza without somebody having to feed him. So if you think about how important that is to eat your own slice of pizza, hold it for yourself. So when he was ready to start using this, we bought him a whole pizza. And he sat there until he was finished with every bite of it. All right. Oh, no. Okay. Okay, another option for FES is to use an EMG signal to trigger it. So I showed you in his, he uses a joystick, but there's some research with using an EMG signal, so we could put an EMG sensor on the other shoulder, and that could trigger the hand function. So some things to look for, hopefully, in the future, that these devices will be available. Okay, some things to think about for upper extremity function with FES. So patients with acute stroke can increase their functional abilities using traditional therapy combined with FES. So FES would be a nice addition. And there are some commercially available systems, at least in the US, but you can use a device you have in your clinic to help create this. We do need more research in the area with other populations especially, and that hopefully with the freehand system coming back, we'll see this appear in more areas. Okay, real briefly, I'm going to talk about FES for standing and walking after spinal cord injury. This is a system that is commercially available in the US. I don't know if this is available here, called the Peristep. And these are electrodes that you can place. They're all surface electrodes. You place them on the skin. They're placed on the quadriceps. There's one placed near the perineal nerve. And for this one, the stimulation is very concentrated. So to create a step, it creates a withdrawal response. So it's almost like a noxious stimulus is delivered, which causes a whole flexor response based on their spasticity. All right, so it's not a beautiful swing. It's a very spastic kind of a response in swing. And then the third set of electrodes can either go on the gluteal muscles or in the lumbar spine. And the person controls it through push buttons on the walker. So when the patient wants to take a step with the left, they just hit left step. All right, so the user controls all components of that. And the user can also increase the stimulation intensity while they're walking. So if they notice their muscles are fatiguing, they can increase it to allow them to continue walking. There is work going on with some implanted systems for walking. One big place in the U.S. is in our Cleveland Functional Electrical Stimulation Center. They do get people from all over the world that will come there to participate in their research, so it's something that is a possibility. And for the children, we did a lot of research at Shriners Hospital, but don't currently have a system available. Okay, here's another one. This just shows you somebody standing from the chair with FES. And one advantage of standing up this way, as compared to with braces that you need to lock your knee in extension before you stand up, is that it's a lot easier to stand from this position than when your knees are fully extended in front of you. All right, so it makes a big difference. This is a big guy. He's like 6'1". He is, whatever that is equivalent to in metric, I'm not sure. But I worked with him on this system. And his injury level is at T1. So that's not letting me. Well, you can see him taking some steps, so not beautiful, but we'll hit this again. Okay. All right, so someone who has no control in his trunk or lower extremities, so the stimulation is creating that for him. And he just does a regular swing-through gait, but the stimulation has his knees locked out for him. So in that, we are stimulating the quadriceps and the gluteal muscles to allow him to stand. All right, in terms of some other more clinical applications that you can apply are studies that combine the use of FES while walking on the treadmill. So this is an alternative to manually assisted training on the treadmill, or a combination where you may assist them in stance manually but use the electrical stimulation to create swing. So it's a matter of identifying where your goals are to decide in the right intervention. So there are several studies that have looked at combining these approaches in stroke and spinal cord injury. And I'll skip to the next slide and talk about these. All right, the withdrawal reflex that I mentioned to you on the perineal nerve. Did you guys lose your sound? So this is being done by Adele Fieldfote at the Miami project. And when they stimulated for that withdrawal reflex, what they found is that people could increase their walking speed on the treadmill as well as the distance. And they had an improvement in their motor scores on the ASIA examination. So they gained some functional strength. And a study that was done by Postons looked at multiple muscles. And there they were stimulating for extension and for flexion, depending on what they determined were the patient's needs. And this was acute injuries. And they found also you could increase the distance on the treadmill as well as over ground. And they were able to increase their walking speed over ground. So again, just combining the two techniques. And then in stroke, there's some work going on with stimulating the dorsiflexors and the plantar flexors by Dr. Binder McLeod's lab at the University of Delaware. So they're trying to create dorsiflexion as well as push-off. And some of their early results are showing that they are getting improvements in both knee flexion as well as dorsiflexion. That people can walk faster, they're more energy efficient, and there were improvements in some functional activities, so the timed up and go, as well as the 6-minute walk. And in Cleveland, there's some work with multiple muscles. These are percutaneous electrodes in this case, doing training on the treadmill with FES, and finding many improvements in gait, including some of the joint kinematics during gait. Okay. All right, we're going to talk a little bit about cycling. When do we have a scheduled break? Because I'm going to run into the next lab session. Do we have someone here who can answer that for me? What's that? Take a break now? Okay. All right, why don't we take a break now, and then we'll come back and talk about cycling.